Good afternoon, ladies and gentlemen, and welcome to today's White Cane Week Summit, which will feature an in-depth discussion by leading experts in eye health, ophthalmology, optometry, and research science on just what is preventable vision loss and blindness. The discussion will also take a look at the main causes of vision loss and blindness and the burden it places on Canada's health system. The panel discuss where we need to go in considering the state of vision health in Canada, focusing on the following issues: the incapable reality of unmet need, eliminating the COVID-19 backlog, and the call for comprehensive eye examinations for those most vulnerable, our children and our ever-increasing aging population. At the completion of our presentation, we'll respond to your questions. You have two options. Put them in a question and answer box at the bottom of the Zoom, or two, email Morgan at educationfightingblindness.ca. On behalf of the Canadian Council of Blind, we'd like to take and thank all our healthcare workers and their support staff for the remarkable work you've done throughout the pandemic. You are on the front lines battling the coronavirus day in and day out. You put your patients' lives ahead of your own. Your service to your patients is saving countless lives and has enabled so many of us to begin to return to living a normal life. You have been sensitive to the needs of people living with vision loss and thereby made their lives more tolerable and less lonely at this difficult time. Your dedication, commitment, and courage deserve our deepest gratitude and admiration. In addition to healthcare workers, CCB would also like to thank the many thousands of other frontline workers that have helped us weather the pandemic. To all those who have helped provide us with essential items and services, we extend our gratitude, respect. Your selfishness has helped us through these difficult times. The CCB recommends that everyone gets fully vaccinated, including a booster shot, and that each of us follows all the local and provincial guidelines and recommendations. If we all work together, we can minimize the worst aspects of the pandemic. Dr. Keith Gordon is the Senior Research Officer of the Canadian Council of the Blind and the Principal Investigator of the Cost of Vision Loss in Canada study released by CCB in 2021. Dr. Gordon is a past Vice President Research of the CNIB and the past Research Director of Blind and Low Vision New Zealand. He is Chair of the Board of Balance for Blind Adults and the Chair of the Board of the International Organization of Retina Action. He is an adjunct professor in the Department of Ophthalmology and Vision Sciences at the University of Toronto and an honorary teaching fellow in the School of Optometry and Vision Science at the University of Auckland in Auckland, New Zealand. Ladies and gentlemen, my colleague and friend, Dr. Keith Gordon.
Thank you very much, Mike, for your very generous introduction. And thank you for giving me this opportunity to present some recent data that will set the scene for today's discussion. The underlying issue behind what I'm about to present is ultimately that Canada is in desperate need of a far-reaching, coordinated national plan for vision health. The government of Canada has made several commitments to developing and implementing such a plan, but has failed to deliver on these commitments. In 2003, the Canadian government made a commitment to the World Health Organization that it would develop a vision health plan for Canada by 2007 and implement this plan by 2009. To date, there is no such plan. And then, as if to make it worse, in 2013 and again in 2020, the Canadian government made similar commitments to the World Health at the World Health Assembly. And then in July of last year, they supported a unanimous motion in favor of vision health at the United Nations General Assembly. So this is one commitment after another from the government of Canada to develop a vision health plan. And to date, we have seen no movement towards such a plan, and certainly there's no implementation. before I go any further, I just want to mention that the slides that I have up here are basically slides for me. They're all text, so I will be reading the slides. So if you can't see them, don't worry, I will be covering it. And there are a couple that have a couple of graphs on it. I will be describing them to you. In order to develop a vision health plan for Canada, it's essential to understand the extent of the issue through the use of evidence-based data. The most recent data on prevalence and cost of vision loss prior to last year was 2007. That was a study done in 2009 using 2007 data. So towards the end of 2020, the Canadian Council of the Blind decided that it was really important to start developing the evidence base for future planning. And we commissioned Deloitte Access Economics to conduct an updated assessment using 2019 data. The results were released in May 2021. This slide is, I was trying to get a bit cute. It shows a COVID virus. And what I was trying to get across was that the data that we did in the initial Deloitte study that came out of that was what happened pre-pandemic. But as we got into the study, we realized that the pandemic was having a major impact on some of the issues. So we asked Deloitte to look at conducting an addendum, which would look at the impact of the pandemic on the prevalence and cost of vision loss. So let's get to the findings. This is the background. We've found that there are an estimated 1.2 million Canadians living with vision loss. This represents about 3.2% of the Canadian population. And then we broke this down into three categories: people who were severely blind, people who were moderately blind, and people who had mild vision loss. So we had the severe blind came out that there were 49,500 people who had severe blindness defined as best corrected visual acuity less than or equal to 2200. There were about 417,000 in the moderate category between 2060 and 2200, and about 750,000 who had mild vision loss between 2040 and 2060. This was a pleasant surprise to us, as the previous study done in 2007 showed that there were more people with severe vision loss. And we think that a lot of this has to do with the new treatments that have come up in the last 12 years, in particular the anti-Vegf treatments that have moved people from the severe vision loss category into the moderate or mild category. The results showed that about 54% of people with vision loss were over the age of 65. This again was a bit of a surprise, as we always think of people with vision loss as being that much older. Well, they are in general, but it's only half the population are over the age of 65. And we found that about 1 in 5 people over the age of 85 had vision loss. So that means that if we all know somebody who has vision loss. We all know about 5 people over the age of 85. And if you want to understand what people are experiencing when they go through vision loss, speak to one of those 5 people. We then looked at, if you take these 1.2 million people, we broke it out by the major eye diseases that may be causing the disease. We found the largest group of people who had their vision loss was caused by cataracts. That was 37% of the population. 15% of the population had age-related macular degeneration. 11% had glaucoma, and 9% had diabetic retinopathy. There is then another whole group that accounted for 28% of people with vision loss, which we called other. And other was a wide range of conditions, ranging from corneal diseases all the way through to inherited retinal disorders. So there are a lot of things in that other category, but there was not one that is as big as macular degeneration, glaucoma, diabetic retinopathy, or cataracts. I have on the screen a slide showing the bar graphs of the prevalence of vision loss by province. It's only here to show that we did break out the vision loss by province, so that if you're trying to do some advocacy for any issue within a province, there is data available there. The two largest provinces were Ontario and Quebec. Not surprisingly, Ontario showing 466,000 people with vision loss, and Quebec with 284,000. We thought it would be useful to look at what would happen if we continue doing whatever we're doing, not saying that we're doing nothing, but continue to treat vision loss the way, or vision health, the way we have been treating it over the next 30 years. And we projected that the number of 1.2 million people with vision loss would increase by 2050 to around 2 million. So it's almost double over the next 30 years. So if we want to bring that number down, we've got to do something different. We've got to do some comprehensive planning. So that is the people living with vision loss. Then we thought it's important to look at how many people are living with an eye disease that may lead to blindness. And we estimated that there were about 8 million Canadians currently living with an eye disease that may eventually lead to vision loss. 2.5 million of these people are living with macular degeneration. 3.7 million are living with cataracts, 1 million with diabetic retinopathy, and almost 750,000 are living with glaucoma. So these people are not displaying any symptoms currently of vision loss, but they are waiting in the wings. Many of them are not aware that they even have the disease, but this is where I think focus should be to prevent the conversion from the state where they have no vision loss to a state where they have mild or moderate or severe vision loss. Moving on from prevalence to cost, we did an estimate that the total cost of vision loss in Canada in 2019 was $32.9 billion. This is billion. And this consists of a total financial cost of $15.6 billion and a lost well-being cost of $17.4 billion. The financial cost is real cost. It's the cost of healthcare, the costs of hospitalization, things of that nature, the cost of lost productivity. The lost well-being cost is not a financial cost, but it's a metric that healthcare economists use to evaluate the impact that a disease or condition is having. Then we did something that has additional that hasn't usually been done in this kind of a study. We estimated the direct health system cost of falls due to vision loss. And we estimated that to be $105 million. Now, usually the people who study falls are fully aware of what the total cost of falls is, but nobody's actually broken it down and said, hey, this is what falls due to vision loss is. This is people falling because they can't see very well. And we estimated that across Canada as being $105 million annually. I've got on the screen a table of how the direct healthcare system costs broke out, and I'm just going to deal with two of them. The first one I'm going to talk about is the cost of pharmaceuticals. That the total direct health system cost was $9.5 million. Sorry, $9.5 billion. The cost of pharmaceuticals was this is million. Is million? Anyway. Yeah, it's million. So 9.5 million is the total direct health cost, and the total cost of pharmaceuticals is 1.3 million. This has gone up substantially. Sorry, I'm sorry, I'm having a blank here. It's billion, it's $1.3 billion. And it's gone up from about 500 million to about 1.3 billion over the last 12 years. A lot of that is due to the advent of anti-VEGF treatments for macular degeneration, diabetic retinopathy. So there is that additional cost, but the benefit is that we, as you've seen, that we have fewer people with more severe vision loss. Now, the other cost here is that vision research, we went looking for how much vision research is cost in Canada, and we found that a total expense for vision research in Canada is $20.9 million. This is million. So we looked at research done in psychology and psychophysics. We looked at genome research. We looked at every type of research that could be related to vision, and found a miserable $20.9 million being spent on vision research in Canada. This is abominable, and if we want to tackle preventable vision loss, this has to change. And Doug is going to talk more about that a little later on. Okay, so the results I've just talked about are all pre-pandemic. So what happened, what impact did the pandemic have? And we looked at a number of factors, and our key findings are on the next slide, which I will speak to. We found that there were almost 3 million fewer visits made to optometrists in 2020 compared to 2019. So fewer visits to optometrists results in fewer people getting early diagnosis for eye disease, which in turn can lead to vision loss. We estimated that there were 143,000 eye surgeries that were missed or delayed in 2020 compared to 2019. And there were almost 70,000 fewer anti-VEGF injections for macular degeneration or diabetic retinopathy in 2020. People are getting these injections to stabilize or improve their vision. And if you miss an injection, you're going to lose vision. So this was all of what I presented for these three findings can lead to significant vision loss. And we projected that there were almost 1,500 people who experienced some level of vision loss due to delayed eye examinations and treatments such as eye surgeries or anti-VEGF injections in 2020. This is preventable vision loss, and with a proper plan, I believe that a lot of this could have been prevented. We also showed that wait times for cataract surgery increased by 31 days in 2020. There were a few other findings, but those are the main ones. And so what's going to happen? How are we going to get over this? How are we going to continue on the downslide? Well, we feel that it's really important to assign additional surgery time, assign additional resources of various sorts to make sure that we can turn this around, and to use Mr. Biden's phrase, I'd like to build back better. It's expected that it will take 2 years to clear the additional backlog of cataract surgeries caused by the pandemic. So that's in addition to what the cataract surgeries that are going to be needed in the next 2 years. And it's expected that an additional $129 million a year will be required just to clear the backlog in cataract surgery between 2021 and 2023. So that's a lot of information, but I've just got 3 takeaways that I think will set the scene for the talks that you're about to hear. The 3, if you remember anything from this, there are 3 things. The first one, there are 1.2 million Canadians living with vision loss. Second one, there are over 8 million Canadians living with a blinding eye disease that could lead to vision loss if untreated. And the third one, the government of Canada needs to develop a national plan for vision health in Canada, as well as a vision desk at Health Canada. 1.2 million, 8 million, a national health plan. That's all my talk was about. So thank you very much for this opportunity. It's over to you, Mike.
Thank you, Keith. Our keynote speaker is a South African optometrist and an academic at the University of KwaZulu-Natal. Dr. Diane Van Straten holds a master's degree in public administration, as well as a doctorate in development cooperation from Dublin Institute of Technology in Ireland. She has contributed to eye health policy development and optometry training in several countries, holding various leadership positions in academia and within the global eye health sector over the last 15 years. She's an active researcher in her field with several key publications advocating for improved eye health services within countries. In February 2020, her paper, The Universal Eye Health Imperative for Canada, An Inescapable Reality of Unmet Need, was published in the Canadian Journal of Public Health. She is a senior lecturer in optometry with the academic leader for teaching and learning within the School of Health Sciences at the University of KwaZulu-Natal in South Africa. She's also currently visiting the assistant professor at the University of British Columbia, Okanagan, collaborating with the university with UBCO faculty on health equity related research products. Ladies and gentlemen, it is an honor and privilege to present Dr. Diane Van Straten.
Thank you very much, Michael, for that warm welcome and introduction. And it's a pleasure to address the seminar today. I do see Morgan's hand is raised. Perhaps she wanted to make a comment before I give my talk. Morgan?
I think you're good.
Okay, awesome. All right, thank you. Then I'll just share my screen. That good?
Yep.
That looks good. Yep, perfect.
Excellent. Well, I decided to address or entitle my talk today, Reducing the Burden of Preventable Vision Impairment. On the back of the paper that Michael mentioned was published in the Canadian Journal of Public Health in 2020, where I spoke about the inescapable reality of unmet need in terms of eye care in Canada. And just to put it in context for the audience, while I'm South African, I've spent the last 15 years or so working on eye health equity related work globally in various countries, mostly developing countries, but also developed countries. And so I'm very passionate about addressing the unmet need for eye care. And I trust that the background that I bring today, as well as some of the highlights that I will present in my talk, will put context to why there's an urgent need for scaling up Canada's efforts towards addressing preventable vision impairment. So I thought I'd map out personally where I've journeyed along this path of addressing unmet eye health needs. At the start of my career, I graduated as an optometrist in 1999, and that was the year that the International Agency for the Prevention of Blindness launched Vision 2020, the Right to Sight, which I'm sure many, if not most of you, have heard of. And that was a charter that commissioned the world to take action against all forms of avoidable vision impairment or preventable blindness. And at the time, there were 5 priority conditions that were targeted, which included cataracts and glaucoma, which I was very surprised to see in Dr. Gordon's presentation remains a challenge in Canada, even in 2020, as per your latest data. So my early introduction to the fight against avoidable vision impairment was right at the beginning of my career. So I'm going to touch on these eye health advocacy milestones from 1999 to 2019 and move on to beyond 2020 and why it's imperative that we must scale up action. Moving on from Vision 2020, there was lots of action globally amongst NGOs and various countries and organizations advocating for improved access to eye health services. In 2010 in Durban, which is my hometown in South Africa, the world came together at the World Congress of Refractive Error and Service Development, which was ophthalmology, optometry, health personnel from the IAPB and WHO. And that resulted in a Durban Declaration where participants at the conference agreed to work actively towards addressing these causes of avoidable vision impairment, which were cited in Vision 2020. And with various, using various different strategies in different countries, and of course at different paces, countries address their individual needs as their means allowed. The next milestone I'd like to point out was the Global Action Plan, which was a World Health Organization plan from 2014 to 2019. And that really was underpinned by this concept of universal eye health. And I'll touch on universal eye health in one of the upcoming slides. In 2019 as well, the World Health Organization released the World Report on Vision, which highlighted the reality that there are 1 billion people in the world who are suffering from causes of blindness or vision impairment, which could have been prevented. And this is an indictment on health systems, countries, eye health professionals, organizations, given that Vision 2020, the right to sight, was launched in 1999. And 20 years later, we're still flagging the issue that there are 1 billion people in the world who are suffering from avoidable or what could have been preventable causes of vision loss. And so this means that much more needs to be done to address the growing eye health needs of populations all over the world, not just in Canada. Just last year, there were 2 very important milestones. The Lancet Global Commission on Global Eye Health was released, and I'm going to touch on a few of the key points that came out of that report. And then I think it was in August last year that the United Nations made its first ever resolution on vision, which basically stated that eye health needs to be seen as an integral part to achieving the United Nations Sustainable Development Goals. And so eye health was picked as a development issue, intertwined into many of the other goals, which I will highlight on the following slide. But the slide just up is the overarching message out of the Lancet Global Health Commission on Eye Health, which was published last year, was that improving eye health is a practical and cost-effective way of unlocking human potential. There's plenty of evidence to show that vision impairment impacts an individual's quality of life, their ability to earn an income. It affects their job prospects, in so many ways, social engagement, mental health. And so if we look at eye health as a core part of overall health and well-being, as defined by the World Health Organization's definition of health, that it's not merely the absence of disease or infirmity, but it's well-being all round, and eye health is an integral part of that. Then we must look at what we can do, not just to prevent blindness, but how can we promote eye health very early on in the health system so that we do taper off and reduce the number of people who will need longer term care or rehabilitation for more complex eye conditions. So this slide just shows the Sustainable Development Goals, and eye health is linked to at least 5 of them. There are many papers that have been published that link vision impairment and blindness to poverty. And we know if people can't earn an income, it can also affect their ability to eat healthily, affect overall health and well-being, which is goal number 3, particularly in developing countries. Vision impairment does impact a child's chance of getting a quality education. In many countries as well, there's a definite gender imbalance in terms of accessing eye health services. And overall goal number 10 is what we must aim for as an eye health communities. How can we reduce the inequalities in the health system when it comes to accessing eye health over other health services, or dependent on where a person is in the country, whether they're in an urban area or in a rural area? Does that affect their ability to access services? And if it does, then it's certainly going to increase the burden that is placed on the health system in years to come. So removing the barriers to accessing eye care is critically important. So what is universal eye health? And Canada has a health system that is structured around universal health coverage, which means that all individuals and communities should receive the health services they need without suffering financial hardship. Essentially, that it shouldn't place a financial burden on individuals simply to access a health service. And one of the things that have really bugged me as an eye health professional over the years is the way eye health has been sidelined in the health sector. Across the world, in various countries, it's seen as a non-priority service. Other services are prioritized over eye health. And this is why we see the ballooning of costs when it comes to treatment, particularly for those conditions which emerge in older age, like glaucoma and diabetic retinopathy, which by the time someone is diagnosed, they are very often needing rehabilitative type care, which tends to be more costly to the health system. Whereas if they had routine access that wasn't a financial burden on them and went for routine eye exams, the condition could have been detected earlier, most likely, and then reduce the debilitating effects that could have taken place. Secondly, universal health coverage also talks to a full spectrum of essential quality health services, from health promotion to prevention, treatment, and rehabilitation across the life course. And the reason why I've underlined across the life course is this is where the challenge comes in for Canada. When I wrote the paper that was published in 2020, I realized that there's very segmented access to eye health services in Canada. And while the provinces generally have sort of slight variations in terms of their health insurance coverage, there certainly is a large percentage of the population that doesn't have ready access, that's not a financial burden to them. So this is the problem, or the main problems I extracted from the Lancet Global Eye Health Commission. It highlighted the fact that almost everyone will experience a vision impairment during their lifetime to some extent, whether that's simply, just presbyopia and needing a pair of spectacles to correct the near vision, or whether it's something related to a systemic condition. The graphic or the visual I have on the slide shows that in almost all societies, there's a segment of the population who is not excluded from care, but certainly has more difficulty accessing care. In my own country, where I come from, in South Africa, the estimates are that almost 80% of the population does not have ready access to primary eye care services. And therefore, we face the same challenge. If people are not having routine eye exams, things like glaucoma, diabetic retinopathy, age-related macular degeneration will get diagnosed much later in much more advanced stages and end up costing the health system more. The second problem that the Lancet Global Eye Health Commission highlighted was that high-quality eye health services are not universally delivered in most countries, which we know is the case in Canada as well. And Dr. Gordon also touched on that in his presentation. So the realities, again, from the Lancet Global Eye Health Commission, they've done an extensive study as well globally. And we know, I know some of the studies you've done as well, Dr. Gordon, is that cost-effective vision restoring interventions are available. The graphic there is sort of a tongue-in-cheek pharmaceutical label that says, named lean thinking, and the warning is that it contains common sense. And sometimes it just comes down to how health financing needs to be restructured in order to meet a larger segment of the population's eye health needs, and not looking at it as sort of as an expense, but rather an investment into the health of the population. And if that's done at a lower level of the health system, at the level of promotion and prevention, certainly in the long term, there will be a saving for the health system. Dr. Gordon also mentioned staggering statistics, how this avoidable blindness and vision impairment is costing Canada billions of dollars. So I think, the challenge is to rethink how eye health is financed in the country in order to meet the growing demands for care. The second point in terms of the reality we face is that financial barriers to accessing eye care leave many people behind. And this is a fact all over the world, that eye health typically tends to be an out-of-pocket expense for many. And when they can't afford it, it's neglected and the consequences become more dire. So the current gaps that we know of is that in most countries, the eye health workforce is unable to meet the population health needs. So essentially, we need more ophthalmologists, we need more optometrists, we need more ophthalmic nurses and whatever designation, but we need more personnel to address the eye health needs in countries all over the world. And so training must be scaled up. Secondly, reliable service data is scarce across the globe, but this is key to progress in eye health. We need to know what is happening on the ground, what is working, what are the statistics from the service centers that can inform how money is spent or how services are streamlined. The third gap is that research is lacking, but is crucial to understanding how we treat eye diseases, as well as how the health system functions when eye health is integrated into the health system. And the last two that I mentioned there, is, excuse me for that. We know that there are barriers to accessing eye health services, and these are the ones we have to reduce these in order to address unmet eye health needs. Excuse me. So how do we go about addressing the eye health needs of Canadians? Well, I looked at the Canada Health Act, and it's got a very noble ideal of wanting to protect, promote, and restore the physical and mental well-being of the residents of Canada, and to facilitate reasonable access to health services without financial or other barriers. And I think that's commendable. But in reality, is it happening in terms of eye health service delivery and access? And from what I've read and heard, it doesn't seem to be the case. It also states that health insurance plans must ensure and support accessibility, comprehensiveness, and universality of care for all medically necessary services for the purpose of maintaining health, preventing disease, or diagnosing illness. And there again, I've underlined medically necessary, because when I scanned some of the provincial health insurance plans, certainly, as an optometrist, I think I am biased in terms of, considering routine eye exams medically necessary, because I think lots of systemic illnesses can be detected during a routine eye exam, which we know can have significant consequences for eye health. But in the context of the Canada Health Act, it seems that medically necessary services are the ones that are defined as when you already have a diagnosis that needs more specialized treatment. And I think that intervention is then too late. And of course, it becomes very costly, as I've previously mentioned. So this is the reality of unmet eye health needs in Canada. In most provinces, I think it's roughly up to the age of 19, children can get access to a routine eye exam. And then after the age of 65, their eye health needs are largely taken care of and funded. But there are variations in what I call this missing middle, which I've highlighted the middle segment of sort of working age adults in red, because these are really the economically active citizens, people who need to go out and work. And in many cases, you know, some of these conditions are incipient in those sort of middle adult ages where there's no symptoms, but they've started, the diseases started to take root in the eye or in the body, and then it's advancing. And because generally your eye may not pain from glaucoma or from diabetes, and you'll only realize something is a problem when it's fairly advanced, people will not go and seek help unless it's something significant. So unless we make it easier for this missing middle to access primary eye care services, we're going to continue to intervene rather late and have a high burden of avoidable or what could have been preventable vision loss in Canada. So I'll just snap over this because I think it has been said that there are many implications for unmet eye health needs. And these include individual implications, be it health, social, or economic, that affects an individual's quality of life, and then also the societal implications, not least of which is the cost to the health system, but secondarily, the participation of people with vision loss in various segments of societal life is critically important to a whole and a well society. So my take-home message is that access to services is key to controlling vision impairment and blindness. And I'd like to argue that access to services for many Canadians is currently still a significant challenge. So in order to improve eye health services, the slide, the graphic that I have here, I think central to that is the development of an eye health policy. Without a guiding policy, it's very difficult to plan and fund eye health services. So Dr. Gordon had mentioned that in 2003, Canada was a signatory to World Health Assembly Resolution, I think it's 56.26, if I'm not mistaken, which said that at that point, within the next 3 years, they will develop a policy and establish an eye health desk, which is 19 years thereafter, and Canada still does not have an eye health policy. So central to improving eye health services and access to eye health services for Canada is the imperative to establish a national eye health policy, which will inform health financing, treatment technologies for eye health, research, and we've heard that research is significantly underfunded in eye health, as well as enable service capacity. So my final message is that, you know, back in 1999, at that time, the world was quoting 80% of cases of visual impairment are preventable or treatable. That percentage has come down to about 75%, but still significant. That means 2 out of 3 people who become visually impaired could have been treated if it was detected early enough. And as an optometrist, I have to say that access to routine primary eye exams supports early intervention and treatment. And with that, my final message is that Canada must act now to reduce avoidable vision and impairment and blindness by 2050, as is the ideal. So I trust that that sort of paints a picture of, you know, where we are at from 1999, 23 years later, with no eye health policy and still significant gaps in access and treatment. I think the time is now for Canada to act. Thank you very much, Michael. Over to you.
Mike, are you there?
I left it on mute, sorry. Thank you very much. I'm surprised they let you out of South Africa, Diane. You've got a lot to offer, and we're glad to see you're here in Canada and have been for a while. I think that I really want to review what you've just said, because it's got lots to offer into the directions that I know Canadian Council of the Blind and other stakeholders want to go. So thank you very much, Diane.
It's a pleasure, Michael. Thank you for your kind words.
Dr. Marco Popovic is a third-year resident physician in the Department of Ophthalmology and Vision Scientists at the University of Toronto. He is also a Master of Public Health candidate in epidemiology at Harvard University. He's been published widely and is a recipient of numerous conference awards from the American Academy of Ophthalmology, American Society of Cataract and Refractive Surgery, Canadian Ophthalmology Society, European Society of Ophthalmology, and Retina. With that, I'd like to introduce Marco Popovic.
Thank you very much, Michael, for the kind introduction, and I'll just start with my slides. And thank you very much to previous speakers on their excellent presentations, and to the Canadian Council of the Blind for this opportunity. So my talk will go into basically a case presentation looking at diabetic retinopathy as an example, trying to see where are we at right now in terms of screening and diagnosis of this condition, and where can we be in the future, depending on innovation and research. And so no relevant conflicts of interest to disclose for this presentation. So to begin, diabetes, as we know, is endemic within our society and across the world. The incidence of this condition is right now at around 170 million individuals worldwide, and is expected to rise dramatically to over 300 million individuals by the year 2030. Diabetic retinopathy is a significant contributor to vision loss and can really induce blindness in many individuals if left untreated. So to begin, before going into all of the potential advances in the management and assessment of this condition, we need to start with the fundamentals as to what is the current standard of practice. And so for diabetic retinopathy, we know that sequential examinations, typically yearly, are done by the retina physician, ophthalmologist, or optometrist. And that can be supplemented with imaging modalities, specifically OCT, or optical coherence tomography, which I'll show in a later slide, has really revolutionized the way we think of this condition. These are just representative photos giving you an idea of the differences that we see in normal eyes versus those with diabetic retinopathy. So if you start here on the top left, you see a normal appearing retina with normal vessels. The optic nerve looks preserved and the media looks clear. As we move along these panels to the right, you see kind of early changes of diabetic retinopathy. The vessels become more tortuous, become dilated, the new microaneurysms form, maybe small hemorrhages appear. With time, chronic fluid leakage from these impaired vessels leads to exudation, which you see here on the middle panels as these kind of yellow areas over the center part of the retina. And then if left untreated, that develops into neovascularization, meaning that the retina becomes essentially starved for oxygen. And the way that it compensates for being starved for oxygen is that it creates new blood vessels. And those blood vessels are very friable and can easily break and lead to large, visually significant hemorrhages that you see on the bottom panels here. And again, if all of that is left untreated, the retina could essentially wrinkle and develop into a retinal detachment as a result of advanced diabetic retinopathy. So this is an example of an OCT scan. So this is essentially a cross section of the center part of the retina called the macula, giving you an idea differences between the healthy macula here on the left, where the levels of cells along the macula are preserved, in contrast to the scan on the right, where you see a significant amount of fluid, the dark areas there, in a case of diabetic macular edema, meaning that that there's been a significant amount of leakage of fluid in the center part of the retina. And so in terms of treatments for diabetic retinopathy, we know that the anti-VEGF injections, the injections right into the eye work, specifically in cases of diabetic macular edema, as I showed on the previous slide. Also, as I mentioned, the diabetic retinopathy is a state where the retina becomes starved for oxygen. And so we can apply laser treatment 360 degrees around the peripheral retina to reduce the amount of oxygen demand. And if those treatments fail and a non-clearing hemorrhage develops or a retinal detachment, then surgery, typically in the form of a vitrectomy, is offered. So now that we've gone into the basics around diagnosis and management, next I want to highlight a few advances in both screening and diagnosis for this condition. The first is the notion of telemedicine. So especially for individuals in remote communities, those in northern communities, individuals with mobility issues, telemedicine has provided the ability to take retinal photographs of the patient wherever they are, and to securely send them, along with potentially OCT photos, to their treating eye care professional. And that, in and of itself can allow for, has shown to allow for accurate diagnosis, and to help with planning for treatment. And so, this is a very exciting way of screening individuals with diabetes and diabetic retinopathy who otherwise may go missed. And so this is a map here showing really the burden of unscreened individuals that we're dealing with. So each one of these purple dots here corresponds to 30 individuals with diabetes that are unscreened. And I really want to highlight here the work of Dr. Michael Brent and his team for establishing, in Toronto at least, the Toronto Teleretinal Screening Program. So this program has been hugely successful in being able to reach out to individuals with diabetes who otherwise would not be screened. In a 5-year span, they screened about 1,500 eyes and are really working to ramp up screening through this telemedicine option. The second advance I want to highlight is specifically around taking photos of the retina itself. And so the left-hand picture here, you can see this kind of traditional instrument that's used to take photos of the retina, which is quite complex, large and difficult to integrate in certain settings, such as mobile eye clinics, or areas where it's impossible to transport this type of technology. And so a new advance for actually taking photos of the fundus has been a portable fundus photography instrument. And so that's shown here on the right-hand side. It's very easy to use and carry, and it's non-mydriatic, meaning that photos can be taken without the pupil necessarily being dilated, which presents a significant advantage. An extension to this is, well, why would we need an instrument at all to take photos of the fundus if we could just use our smartphones? And different methods have been developed to use the lighting of smartphones along with the traditional lens that's used to assess the fundus, to be able to capture high quality images of the retina in real time. And so this is something that we have started to use more commonly, especially in difficult and complex cases, in being able to collaborate with our team members. And then the question, I showed on an earlier slide, really just the burden of screening that needs to be, that is given towards eye care professionals to to be able to appropriately screen all individuals with this condition. And so the question then becomes, well, is physician screening or eye care professional screening the only way to do this? And so we know that having eye care professionals screen is associated with high cost, and a significant supply of these individuals is needed. And so one kind of area that's been undergoing a lot of research recently is the notion of artificial intelligence. So these are computerized programs that allow us, after receiving a retinal image, to categorize that retinal image as not having any diabetic retinopathy, having mild or moderate disease, and then having severe disease. And that really is thought to provide information on what type of treatment should be offered. Now, this type of technology, I don't think is still widespread use in clinical practice, but it provides a promising alternative to only having screening by eye care professionals in real time, and provides an opportunity to complement the screening systems we have currently with something novel. The limitations of artificial intelligence-based systems is that to develop these algorithms, a large database of retinal photographs is needed, typically in the thousands or tens of thousands. And really, the artificial intelligence softwares, because they're programmed based on what the ideal diagnosis is from a human grader, they're really only as good as human graders in picking up disease. And so next, just highlighting a couple of advances in the diagnosis of diabetic retinopathy. The first is the notion of ultra wide field imaging. And so if you see here on the picture on the fundus photograph on the left side, this is a photograph of the retina, of like basically the central part of the retina, about 30 to 50 degrees, depending on the system that's used. Newer systems have been able to extend the resolution to include the far periphery of the retina as well, spanning up to 200 degrees. And we know that diabetic retinopathy is a condition that not only affects the central retina, but also in the periphery. And so especially in cases like telemedicine, where a lot of the decision around next steps is based on the photograph that's taken, ultra wide field imaging allows us to identify diabetic retinopathy earlier in select cases, especially those in which the peripheral disease is more prevalent than the central disease. The second technology I want to highlight is something called OCT angiography. And so I showed you previously that nice cross-section of the OCT scan showing us the development of fluid. Well, the next question was taken from that. Well, if the OCT is used so well for looking at the macula, can we apply the same technology to look at the blood vessels and vasculature of the retina? And so you see here on the top left panel how on a simple clinical examination, you do see some level of diabetic retinopathy here for sure, but it may be unclear as to the kind of extent of disease that there is. And then compare that to panel B here on the top, which gives you a representation of the OCT angiography, which shows these large confluent areas of neovascularization that need to be treated. So this really helps us in our diagnosis and staging of diabetic retinopathy, and as well as following patients after they've had treatment to ensure that that treatment has done what it's supposed to do. And so I want to close it there, and thank you very much for your attention, and happy to take any questions. Thank you.
Thanks, Marco. I'm sure there's going to be questions at the end. Doug Earl joined Fighting Blindness Canada in December 2018 as president and CEO. Since then, he has been leading FVC through a transformation to accelerate research in all blinding eye diseases in order to discover treatments and cures for blindness and to improve access to innovative gene and cell therapies and medications. Earl co-chaired the Canadian Vision 2021 summits, consulting with the community to identify its advocacy agenda in these symbolic years. He has worked with philanthropists to fund millions in medical research and other projects. He's a true friend of the vision loss community and the Canadian Council of the Blind. Ladies and gentlemen, with great pleasure, Doug Earl.
Great, thank you, Michael. And I've really been enjoying the presentation from my fellow panelists. So thank you for this opportunity. I wanted to go through my disclosures. Of course, I have no research support in working for fighting blindness, but I do have a bias. I live with an eye disease, and I know many people that have experienced vision loss, so I am biased in my presentation. What I wanted to do was talk a little bit about the findings that Keith, Dr. Gordon mentioned at the beginning of this presentation, and some of the key issues that have been raised as a result. We, as Dr. Gordon mentioned, today there are over 8 million Canadians living with a blinding eye disease that if it develops, if it moves down a pathway that puts them at significant risk of losing their sight, of leading to blindness, if we don't have early diagnosis or access to treatment. You need both. That early diagnosis that Dr. Van Staden mentioned, but also the access to treatment. And the numbers are just staggering. It's 8 million now, but it's going to be over 13 million living with these diseases. So in 2050. And so we have a role in Canada, especially in our healthcare system, in our society, to really prevent that blindness, because research has delivered treatments that, if diagnosed early and you have access to those treatments, 3 out of 4 can have their sight stabilized. And even if diagnosed early enough, in cases of age-related macular degeneration or diabetic retinopathy, the damage can be reversed by the treatments. So it's absolutely critical that we have that access to a regular eye exam in order that we can diagnose and access treatment. The second, of course, is the 1.2 million people that have uncorrectable vision loss today that Dr. Gordon mentioned. That's and we're anticipating a 67% increase to 2 million by 2050 if we don't change our health policies, if we don't develop strategies to ensure these regular eye exams and access to treatment occur. And it is fundamental, and it's having an impact on all of us, not only for my friends and the community, but also society as a whole. Because as Dr. Gordon mentioned, we found that $32.9 billion was the social economic cost of vision loss in Canada. And without changes in health policy to prevent blindness or investments in research to restore sight for those who have uncorrectable vision loss today and in the future, that number will grow in 2019 dollars to 56 billion. So that there is a human impact on each of us, the lived experience that we share, but it's also for society as a whole. There is an impact which drives why we should be very active and proactive in demanding our rights, standing up and being heard to have access and to treatment and to have access to these regular eye exams. I also wanted to highlight, Dr. Gordon did mention the cost of pharmaceuticals at being at $1.3 billion. That's $1 billion more than the last report. And that's an incredible investment by the healthcare system into treatments. And it is, Dr. Gordon noted, that it did have an impact. First off, the direct costs of healthcare flatlined in the last 10 years. One is because good policy decisions were made to give Canadians access to new treatments for glaucoma, new treatments for cataracts, and anti-Vegf treatments were introduced into the Canadian healthcare system in 2006. And over 100,000 Canadians are receiving those treatments each year, stabilizing their sight, preventing blindness, which is amazing. And despite the fact that there was $1 billion more spent in pharmaceuticals and new treatments, we did not see any direct increase of health costs because we were having an impact in preventing blindness. So that's absolutely critical. But there is unintended consequences when health policy does not change for the better. Like the decision made by the Ontario government in 2004 to remove, as Dr. Van Staden called them, that missing middle, those adults between over the age of 19 and under the age of 65. And just one example, Dr. Popovic mentioned the diabetes work that Dr. Brent's doing and others. In 2004, 70% of adults living with diabetes, so in that missing middle, accessed a publicly funded regular eye exam. Fast forward to 2017, that number had dropped to 60%. So we went from 30% of people living with diabetes, even though it's covered by public health care, to 40% not accessing this regular eye exam, which if you're diagnosed early, as I said, anti-Vegf treatments can help you prevent vision loss. So these are health policy decisions that have been made, positive ones, introducing new treatments, but on the other side, policy decisions that create barriers to access, even unintended barriers, like I was pointing out with diabetes. The other finding in the report was, of course, the flatlining of cataract surgeries in the last decade. Even though we've had over a 50% increase in the number of people living with uncorrectable vision loss, and we've had a tremendous growth in the number of people, over 8 million people living with a blinding eye disease that puts them at risk. The number of cataract surgeries has basically stayed the same. It's only gone up 5,000 surgeries, publicly funded. And, it's no surprise that 2 out of 5 of the 1.2 million that have uncorrectable vision loss has that uncorrectable vision loss was caused by cataracts, 2 out of 5. And that's a health policy decision that we need to change. We need to ensure that there's greater access to these cataract surgeries. In Canada, there should be no barrier. We should have the medical staff available. We should have the OR time available, and we should have the opportunity for people to get, when they're diagnosed, that the wait times. And as Dr. Gordon mentioned, 143,000 canceled surgeries because of COVID in Canada that we found in our addendum last year, between March and December 2020. We figured in our report that it's going to take over 2 years for that backlog to be cleaned up, and we were already experiencing people with greater wait times because of the flatlining of surgeries. So I wanted to talk a little bit about the work that we're doing at Fighting Blindness Canada, at the Canadian Council of the Blind, in order to try to improve access to innovative treatments in order to prevent blindness and that Canadians can have access. So in the last basically 3 years, we have worked together, the Canadian Council of the Blind, Fighting Blindness Canada, CNIB, our partners have worked together in order to provide what they call patient input. It's really lived experience about what a new treatment could mean. And we've had some success. I wanted to talk around, the first glaucoma medication, new medication in 20 years, was approved, and it's available now. We're at the end, hopefully the end of the process of getting this medication. It's been 3 years since it was approved by Health Canada, and still people in the province of Quebec do not have access to this treatment. We're working on it, but we've not been successful. There have been 2 new anti-VEGF treatments. One of them was approved, and it's been well over 24 months since it's approved by Health Canada, that for the first province, Ontario and New Brunswick, 2 provinces, have approved the treatment to be publicly funded. The second new anti-VEGF treatment is just right now being reviewed by Cataract. We are, as our vision community, are speaking with one voice and making the input, patient input submission, just, I think it was done yesterday, actually, to ensure our filing is why it's important to have options for these anti-VEGF treatments. And of course, the community came together and provided reports. We weren't successful on a national basis to get access to minimally invasive glaucoma surgery devices or techniques, but we were successful with one of these new devices with the Ontario agency that makes recommendations for new treatments. We were successful last spring to get it recommended for public funding. We have a lot more work to do on this front. And I wanted to just share this slide, whether you're visually living with vision loss or not, is no different. It is confusing, it's hard to see and understand. It is Canada's drug approval process, and starting with research and development to create these innovative treatments, going to Health Canada to whether or not it's safe to be approved as a treatment. You know, what is the price with the Patent Medicines Price Review Board? They're changing those regulations right now, and we've, as a patient organization of people living with vision loss, we've not been satisfied with the assurances that the system is going to increase or maintain the access that we have to innovative medicine. So we're raising questions. It's been delayed 3 times in part because of people with lived experience speaking up. And then in the middle of this slide is a Byzantine process. There's this thing called Cataract, which, you know, very few people actually know what those acronyms stand for. And NAS, which is the Quebec body equivalent. Cataract is for the Canada, the 9 provinces and the 3 territories. And then this office called the Pan-Canadian Pharmaceutical Alliance, which does the negotiations, so that the previous Cataract and the NES, they make recommendations whether or not a treatment should be approved. And then the price negotiations may happen, may not happen with the Pan-Canadian Pharmaceutical Alliance. And then each province reviews the results of the negotiation of the recommendations, and they retain the right to say yes or no. That's why Quebec has people in Quebec do not have access to this new glaucoma treatment, because the Quebec government has decided not to take the recommendation from INES and not accept the negotiations that took place and move forward. You know, of course, hospitals and health authorities, they can adopt the treatment as well. And there is a very significant private payer, and it's increasing today. And they have their own price negotiation. The Manulifes, the Sun Lifes, the Canada Life, they've now created something, you know, very similar to Cataract and INES, where they're reviewing medications and increasing. You know, reports are saying that this process, you know, once Health Canada approves a treatment, it can take up to 3 years before we get the first province saying yes. And in many cases, these medications don't make it to public funding, denying access. So just as an example, the last part of this chart, 43% were accepted for public access, 21% you had to pay yourself, and 37% was picked up as prescription drug spending in 2018, according to the Canadian Institute of Health Information. So I want to give an example of the first targeted gene therapy that was approved by Health Canada. And this is no surprise to the Canadian system. They were informed in 2015 that this was coming. An application had been made to the US government's Food and Drug Administration, the FDA, and it received approval in December 2017 that Luxturna would be approved in the United States, and Novartis had the contract to market this product around the world. 25 countries have authorized Luxturna as a treatment. There are 19 countries that have figured out how to reimburse this treatment. Notables like the United Kingdom, no surprise, Germany, Spain, France, but Australia, Austria, even Croatia has figured out how to reimburse this treatment. But 6 countries that have approved it as a treatment in the country have not figured out the pathway for reimbursement. Argentina, Brazil, Canada, Greece, Poland, Portugal. I don't think Canadians would think that we are with Greece or Portugal in making these decisions. We probably think and assume that we are with United Kingdom, Germany, but that's the reality of our system. And the approval process just with Luxturna, we received, the application was received in 2019, November 2019, in order for this. So 2 years after the United States had approved it. CADTH received the patient input in May of 2020, and the community stood up. 537 responses. We would have been happy with 300. We had over 500, and thanks to the Canadian Council of the Blind and CNIB for circulating that invitation, and we circulated it to our contacts as well. Health Canada approved it as a treatment in October 13, 2020. And very shortly, very quickly, the system worked not too bad on the federal level. This was October 13th was within the guideline for Health Canada to review the safety and make it as a treatment. CADTH and INES, within 4 to 5 weeks, made their recommendations that this treatment should be publicly funded. Then it fell to the Pan-Canadian Pharmaceutical Alliance, the office that represents the provinces to do the price negotiation. And it was under consideration for negotiation since January 2020. And finally, after the community stepped up, and we, Fighting Blindness Canada, met with that office 5 times to advocate for it. The provinces agreed to try to negotiate access. It's been 3 months, and there's been no news. That's it is negotiation, so it's under this zone of silence, and it is, we don't know how long would it take, but what we do know is that the Pan-Canadian Pharmaceutical Alliance can move quickly if they want to. Zolgensma is another gene therapy, the second one that was approved by Health Canada almost 2 months after Luxturna. And it was approved by the Pan-Canadian. The negotiations was finalized in October. So if it wants, it can move. We're trying to add our voice to for Canadians to stand up and speak and send a letter, an email to your premier, to your health minister, to your local provincial representative. And it's approveluxturna.ca is the website, and you can punch in your email. There's the landing page there on the slide, and one of our Facebook promotions for people to take action. 5,200 people, Canadians, have sent emails. That's over 18,000 emails to the premiers and health ministers. So thank you if you've gone to approveluxturna.ca. That's unfortunately how we have to gain access to a treatment. And today, 10,000 photoreceptors are being lost by people who have this gene, this treatment. And of course, it's the door opener. It's the first one for eye diseases, because there's more treatments coming. And we're monitoring over 80 clinical trials right now for gene therapies related to inherited retinal diseases, age-related macular degeneration, and dry eye and other conditions. That really, we're setting the precedent with Luxturna right now, and we need you to stand up, send the email to your Premier and Health Minister. Also, how do we gain access? Well, Keith, Dr. Gordon talked around our action plan. We're working with our vision partners, the Canadian Association of Optometrists, the Canadian Ophthalmological Society, the Diabetes Canada, the Canadian Association of Opticians, of course, the old and faithful CNIB, Canadian Council of the Blind, and Fighting Blindness Canada. We're working together to request access to these innovative treatments, to access to regular eye exams. And it's been mentioned by Dr. Van Staden and Dr. Gordon about the National Vision Health Plan. You know, we've made the commitment, Canada's made this commitment, 3 prime ministers have made the commitment, their governments, and the last, of course, the UN General Assembly, where every country in the world unanimously supported vision care for everybody by 2030. So it's long overdue. We need a national vision health plan. And it has real implications. You know, in the UK, during 2020, when the pandemic was on, they declared anti-Vegf treatments an urgent care requirement. And there was, even though the United Kingdom has double the size of population of Canada, almost 15,000 anti-Vegf treatments did not happen compared to the year before. In Canada, with half the population of the UK, that number was almost 70,000. Very different. There's a national vision health plan in the UK. There isn't in Canada. You know, we don't have a forum to create national standards, to create and then drill them down into our provincial and local health delivery systems. A part of that is having a vision health desk in Health Canada, and increasing vision health research has been talked about by the panelists. Absolutely fundamental. Fighting Blindness Canada made a recommendation to increase the CIR, the Canadian Institute of Health Research budget in the government of Canada by 150 million over 3 years, to renew the Diabetes Action Canada SPORE grant. Our report that was Dr. Gordon highlighted, only $21 million being spent in $1 billion Canadian Institute of Health Research, CIHR budget. So access is critical, funding is critical, and that's why you can visit and sign our petition at stopvisionloss.ca. We have to stand up. We have to be heard. And when you sign this petition, it'll be delivered into the House of Commons. It'll be a part of a conversation that we have with Vision Health Month in May with our elected representatives and government decision makers. And this is unfortunately how we're going to get access, so that we can have a national standard for regular eye exams when you need them, and that when you are diagnosed early with a blinding eye disease, that you can access the treatments that you need in order to prevent vision loss. So thank you.
Thanks, Doug. I think what we should do is, we've been running long, so let's turn it over to Morgan and see if we had some questions. And Morgan there she goes.
Here I am.
Okay.
Well, I noticed that our panel have been answering questions as they come in, which is fantastic. Maybe Doug, could you put the link to the petition maybe in the chat? So I'm just noticing a couple of people are asking about that for the approved Luxturna. So we have a couple of questions here. The first one is, since studies show that there was such a low number of adults who are covered but not seeking out services, what has been done to encourage and educate about how it can escalate and the severity of untreated or undiagnosed eye conditions? I think that came in during Dr. Popovic's talk.
So it's always good to have a medical doctor on the panel, Marco.
Yeah. So I think in terms of educating, sorry, I'm just reading the question here. What has been done to encourage and educate about how it can escalate the severity of untreated or undiagnosed eye conditions? I think public education campaigns are really needed and very important. I think with respect to diabetic retinopathy, there are so many individuals who have diabetes, who've had it for a long time, and who just don't know that they have to get eye exams regularly. And I think increasing public education is very important in reaching out to these individuals.
Can I jump in on that? I think it's essential to come back to the whole theme of today, is that if you had a vision health plan for Canada, you would have a public health initiative within there. A vision desk at Health Canada is typically, when you have a disease desk at Health Canada, it's responsible for public health. And part of that public health initiative is public health education. A vision desk at Health Canada should drive public health education and public health awareness of the various diseases and what we can do to prevent eye diseases. Everything from wearing sunglasses when you're out, how to prevent particular diseases through particular initiatives, but all of this should be driven, and on top of it all is the need for regular eye exams.
Can I also just add, we're working with Diabetes Action Canada and Dr. Brent and Dr. Rack around a screening project. So there was work done by Diabetes Action Canada, and we found that the demographics where more people living with diabetes are not taking advantage of that regular eye exam. And so we've targeted 3 health centers in Toronto where those demographics are at the highest in the neighborhoods. And we're working with those health centers to identify people using OHIP billing data with the privacy concerns there in order to be able to identify people who are not taking advantage of the system, and then encouraging them to get a screening and to get diagnosed, hopefully, if they have that disease or in an early stage. And thankfully, the group applied, and now that's being, this project is now being rolled out into 3 other provinces, BC, Alberta, and Newfoundland. So 4 provinces are now doing a pilot study to how to take advantage of our billing codes from our publicly funded system to identify people who can be encouraged. And when we did this at Women's College, over 90% of the people, once they got the notice to come in for screening, they did it. So we're hoping to learn and how to implement this to increase those participation rates so that people can get diagnosed early.
Great. We have another question here in the Q&A about infrastructure. So this person says, Mel says there are 460 ophthalmologists in Ontario, 2,300 optometrists serving a 15 million population. According to a McMaster University study, there are no plans to increase optometrists in Ontario. We do not have the professional infrastructure. Aside from asking for increased funding, what innovative alternatives are the professional communities offering eye care Ontarians to increase access for primary care?
I'm going to just address one aspect of this. The Canadian Medical Association actually did a labor force study for ophthalmologists in this case, and found that 47% of ophthalmologists in Canada are over the age of 50. So 47%, almost half, could be retiring in the next 10 to 15 years. And as Marco can relate from personal experience, it takes a few years to get ready to be an ophthalmologist. So it is actually now time to look and advocate for investments in the residential training programs that Dr. Popovic is in right now. to be able to be trained and ready when that talent pool leaves us. And it is a challenge to be able to have access to these eye specialists, both optometry and in ophthalmology, if we don't make critical investments now, which is a part of the reason why we need this National Vision Health Plan, so we can raise these issues so that investments can be made. Marco, did you want to add something?
Yeah, for sure. I was just going to echo
organizations.
I was just going to echo what you had to say. I completely agree. When you look at the number of residency spots for ophthalmology across the province, the numbers really over a decade have not budged at all. When we know that the population growth has expanded dramatically, and not only in the general population, but especially among those individuals 65 and over. So we recently did a study looking at exactly this question, the number of ophthalmologists relative to the population 65 and over. And we looked at this based on geographical location, based on subspecialty and various practice patterns. And we found unequivocally the message was that relative to those 65 and over, which we know that those numbers are going to increase, each year we're seeing a steady decline in the number of ophthalmologists that are serving those individuals. And so something definitely needs to be done to address the human resources needs in this province for ophthalmology.
Thank you. And I think the only other thing we have here is a comment from Isabel. Isabel says she's a patient advisor with Alberta Health Services, and they're working on a diabetic eyesight prevention strategy to increase the number of people with diabetes taking advantage of their yearly free eye exam. And they're working to include ophthalmologists, representatives of which are on their committee, and they're also using virtual means to access remote communities and First Nations communities, which sounds great. But I think that's it for questions, Mike.
You're on mute.
I just want to ask Diane and Marco and Keith and Doug, if your presentations, if you could make sure Morgan has the presentations and if we can put them up for people that want to view them or pick them later. Any problem with that? I think that would be good. So we can get them sent. We can get them sent to Morgan, and then we'll put them up on the website. We can put them up on yours and our website, Doug.
Yep, absolutely.
Okay. So with that, I want to thank everybody for attending today. You got one more screen to put up, Morgan?
Yep, give me 1 second here. We'll have that up in one moment.
One thing I do, I want to thank, and this is really important, is because I want to thank the Canadian Ophthalmologist Society, and I want to thank the Canadian Association of Optometrists for their support and in working with us relative to the summit and the forums, and we're all looking forward to May. We've had a Canadian Council of the Blind has deferred a number of events. There will be another summit in May along with a joint viewpoint forum, and you'll be getting more information about that. Everybody that's attended today will get copies of White Cane magazine. And finally, I'd like to thank the people that presented the summit today: Allergan, AMI, Bausch & Lomb, Bayer, Bell, Via Rail, Roche, Novartis, and Lab-Titian Thea. We couldn't do it without you. With that, I want to thank our panelists. I want to thank Keith and Dr. Van Straten, Marco, and Doug. Look forward, and Morgan, thank you very much for the work that you put in to make sure that this came off today. So thank you, everybody. Have a good evening, and we'll see you all in May in Vision Month. Thank you.
Thank you.
Thank you very much.
Thanks very much.